Okay, I think this is where we left off with spinal cord injury, slot 76. So let's keep going for just a bit and see what we can do. Spinal cord injury results from fracture, dislocation of vertebra. It compresses, stretches, it tears the spinal cord, causes obvious injury. Cervical spine injuries can result from a hyperextension or hyperflexion of the neck, and with fractures possibly. There could also be dislocation of the vertebra. They may crush or compress the spinal cord in some way that way. Compression usually causes injury to the spinal cord when there's a lot of force applied to the top of the skull or to the feet so that it's compressing downward or upward. The types of spinal cord injuries you see here, this is in your book. It's showing you how the hyperreflection causes the damage there and distortion of the cord, as you can see. Here is a hyperextension where the neck is extended too far back. The same kind of thing is happening to the cord there. Here is compression with a fall, for example, where the compression fracture occurs along the spinal cord. There can be different kinds of spinal cord injuries: simple compression, wedge, and dislocation. Simple is just what it says, a simple line break. Compression you just saw where it's crushed or shattered, maybe in multiple fragments even with that compression. And then wedge is where there's a displaced angular section of the bone. A wedge is displaced, if you will. Dislocation where the vertebra is forced out of position, out of alignment. Damage can be temporary because axonal regrowth can occur, but more often than not, it is permanent. Anytime there's a laceration of nerve tissue by the bone fragments, it's usually a permanent loss of conduction in that tract that's affected. Complete transection or crushing of the cord is irreversible loss of any and all sensory motor function at that level or below. Any partial transection or crushing, some recovery, some function is possible. It really just depends on severity. Bruising is a reversible damage that can occur. Prolonged ischemia and necrosis would lead to permanent damage. You can see that damaged tissue is going to release norepinephrine, serotonin, histamine. Vasoconstriction is going to occur. You can assess the injury and the severity using the dermatome map. Assess movement, assess sensory responses, what they can feel when you touch. Here are the dermatomes. Along the same line, dermatomes, we talked about shingles. And in that case, the dormant virus follows a dermatome as well, and it will follow one of these patterns. I had a 10-year-old at camp who had, I don't know if she had exposure or not. She had what looked like poison ivy. We treated her for poison ivy. And then I determined that what was happening was she had blisters down one arm and across that shoulder on that side. It was following a dermatome. And at that point, I decided that she had a case of shingles. So follow those dermatomes. Spinal shock is that period right after the initial injury, and reflexes are just absent. ANS reflexes absent. The conduction of impulses will cease. There is some recovery possible depending on the amount of bleeding and if there was surgical intervention. Inflammation will gradually go away. Damaged tissue will get removed by the phagocytic cells and scar tissue will form. The scar tissue, however, is not at the same level of function as normal tissue. Reflex activity will resume below the level of the injury, and there may be no communication with higher levels of brain. The control of reflexes below the level of the damage is lost. Those are the possibilities. Spinal cord damage. This is in your book. I'm not going to spend a lot of time talking about it. You can go back and look, but you can see where the shock happens and the repercussions there, and see the point of no reflexes, where there's flaccid paralysis, no sensation, the things that happen there. And as a nurse, what do you have to do, and do quickly? Here are some different levels that you can look at and see, and how things are very different. No voluntary control here at this level. The bottom one here, you may have some spastic paralysis in the legs and bowel and bladder dysfunction. Okay, the spinal cord injuries, we're continuing here. 2 stages in post-traumatic period. Spinal shock and recovery and recognition of the extent of functional loss. Spinal shock initially is where everything ceases below the injury, and even slightly above, just a little bit. There aren't any reflexes. It can persist for days or weeks. Flaccid paralysis. This was on those slides that you saw just now. Sensory loss, absence of reflexes, loss of central control of autonomic function. All of these things with spinal shock. Then recovery. There's gradual return of the reflexes below the level of the injury. There may be no impulses through the specific area of damage. Hyperreflexia can also happen. Gradually, the extent of the damage will be revealed as the swelling and edema and all goes down. Voluntary motor activity. Let me plug up. My battery is running low. There we go. Voluntary motor activity and sensory impulses are blocked at and below the level of damage. A lot of injuries are incomplete, so that there's not permanent damage, but it will vary by individual and vary by severity of the injury. A tetraplegia is a person who is a quadriplegic. They have paralysis of all 4 extremities. There is a paraplegia, which you see more commonly probably, and that is a paralysis of the lower part of the trunk, the legs. So their hands they can use, their shoulders they can use, but pretty much beyond that point, and they can breathe independently, but beyond that point they may not have use of their body or their legs. Ipsilateral paralysis and contralateral loss of pain and temperature sensation, and that depends on the point of decussation and location. Autonomic dysreflexia. Autonomic dysreflexia is massive sympathetic reflex response, cannot be controlled from the brain. This happens sometimes by infection, by genital stimulation, or other stimuli. What can it lead to? Vasoconstriction below the injury, vasodilation above the injury, tachycardia, increased blood pressure. Did I say that? Here is autonomic dysreflexia following spinal cord damage. Okay, I'm going to let you have a look at that more closely. If there are questions, please let me know and we'll discuss it more in depth. Spinal cord injury complications, urinary tract infections, pneumonia, just the muscles aren't working, remember, and so you're not going to take a deep breath. You may not empty your bladder completely. There are lots of different reasons for these things based on spinal cord injury. Spasm and pain, and obviously depression. What is the treatment? Treatment and rehab begin at the time of injury. Start immediately. Immobilize the spine. You've seen the backboards and neck braces that EMTs and paramedics use. Maintain breathing. Prevent shock. There may be traction in the hospital. There may be surgery to repair the tissues, relieve pressure, and to stabilize the spine and prevent further damage. Glucocorticoids, there's those drugs again. Reduce edema, stabilize the vascular system. And then any ongoing care that's needed to prevent complications related to immobility as the treatment progresses and as the person begins to heal and recover. Congenital neurological disorders. These include hydrocephalus, which is too much CSF. It accumulates in the skull. There's a couple of different reasons for it. Either too much is made or the way out to drain is blocked. So there's a couple of things there. Spina bifida is a group of neurotube defects of varying severity. Cerebral palsy, where a group of disorders have some degree of motor impairment, some spasticity, if you will, can be caused by a lot of different things. It may be some sort of abnormal formation in utero, infection we didn't know about in utero, brain damage during the prenatal period, or the perinatal period, sorry. And then there are seizure disorders. Uncontrolled excessive discharge of neurons in the brain called seizures. They can be localized or generalized. There are two basic categories, generalized and partial. Lots of different causes. I told you about my brother who has seizures, and he has both kinds. They're classified by their location in the brain and clinical features. Congenital neurologic disorders. Wait a minute. Okay, this is where I wanted to get into more detail. So here's what I was saying, that the CSF accumulates in the skull. It compresses brain tissue, compresses blood vessels. More is produced than is reabsorbed, and either the overproduction is a problem or the occlusion is a problem, so it's not getting out of there. If their cranial sutures are not closed, then the infant's head is going to enlarge and be very large because those cranial sutures are open and it's able to adapt and swell. There are two types, and that's what we were talking about, non-communicating, and that's the obstruction, and then communicating, where there is a communication, the fluid can drain, but there's too much fluid. The non-communicating kind then is the CSF is blocked. Usually it results from something in the fetus that develops abnormally. There may be stenosis of the tract, neural tube defect. It can be associated with myelomeningocele or the Arnold-Chiari malformation. This leads to back pressure of fluid up into the ventricles. The ventricles enlarge, they compress blood vessels and brain tissue, and if we don't do something, then permanent damage can result. The communicating kinds, absorption of CSF through the subarachnoid villi is impaired. The skull can expand to a certain degree. If not, the brain tissue is going to be permanently damaged. In older children and adults, the intracranial pressure increases more rapidly than in neonates. So the amount of brain damage depends on the rate of pressure increase and the time it takes to get that relieved. Obstruction can be from tumors, from infection, from scar tissue. Meningitis can cause hydrocephalus, and that's what it did in my brother, but it was not a permanent, what's the right word? His skull did not remain big. It didn't get really big. But anyway, okay, I'm going to stop there. Signs and symptoms of hydrocephalus. It depends on the age of the patient. Pupil responses can be light or sluggish. The scalp veins may appear very dilated. In an infant, there'll be a large, lethargic, irritable, and difficult to feed. Their eyes will show the sunset sign, where the white sclera is visible above the colored pupil, so that the pupil looks like a sun setting at the bottom of the eye instead of being where it should be. They have a very high pitched cry when they're moved or picked up, and you'll notice that very high pitched cry. Um, they have to be treated as soon as possible to minimize any damage to the brain. Diagnostic tests or anything that peer inside that head, CT, MRI, they'll all help locate the obstruction. They'll locate abnormal flow. They'll see the stenosis. They'll see whatever is causing this. They'll look at the size of the ventricles and tell if they're enlarged. Treatment then is going to be two different things. Remove the obstruction and put in a shunt. A shunt will take the fluid from the ventricle and will run a tube down under the skin, and it will drain into the peritoneal cavity usually. The shunts don't grow as the child does, so as the child grows, the shunt will have to be replaced to adapt to the size of the child. All right, so spina bifida, or neural tube defects, same thing. They are a common developmental abnormality, and they result from a failure of the posterior spinous processes to fuse together on the vertebrae. So what you see then is a herniation of meninges and even spinal cord outside the body, and that results in neurological impairment, if you can imagine. If we know somebody has spina bifida before they're born, these babies will be delivered early, and they'll be delivered by C-section to prevent any possible damage. Any number of vertebrae can be involved. It's usually in the lumbar area, and the person is usually paralyzed. There is something called spina bifida occulta. And you look at occult blood, and that just means you can't see it, but it tests and it shows up. This is the same way. The spinous processes don't fuse, but there's not a herniation of the spinal cord and meninges outside the body, so you may not know you have spina bifida occulta. One of the ways that we identify it, or think to look for it, is if there is a small dimple in the skin or a tuft of hair over the site where the spine didn't fuse. That will be low on the back somewhere usually. It may be picked up. Somebody may have all of their life had trouble with their back and complained about back pain as a young child, as a teenager, as a young adult. A routine x-ray will show this defect. So there's also meningocele, where the meninges herniate through the defect, and you have a sac on the outside of the body with meninges and CSF. You can transilluminate it to see what's in the sac and see that there's no nerve tissue. A myelomeningocele is more serious because this one does include the nerve cells herniated outside the body. So there'll be a sac outside the body from the spinal cord with CSF, meninges, and nerves. And this person will definitely be paralyzed, will have lots of neurologic impairment below the level of the injury. So here you can see, here's a little tuft of hair, and you can see the meninges there with the defect. Here's a meningocele where the meninges, the lining, and the CSF have pushed their way out through this defect. Okay, but the nerves are still here and probably okay, but there can be some neurodeficits here. This one has nerves that have looped outside the body in the sac and more than likely been damaged. Spina bifida appears to have a multifactorial basis, a combination of genetic and environment, of course. Folic acid is one of the big things we know can help to prevent spina bifida. So if you're of childbearing age, you need to be taking folic acid. Even if you're not intentionally trying to get pregnant, folic acid needs to be taken. So other things, radiation, gestational diabetes, there's your folic acid. High familial incidence. Has anybody else in your family ever had this? Diagnostic test, the AFP level will be elevated in maternal blood. So we check maternal serum to see if there's an elevation. It's leaked from the defect. The specimen obtained at 16 to 18 weeks, usually with an amniocentesis. Okay. We can look at ultrasounds prenatally and see the defect, see the sac on the ultrasound. Signs and symptoms. The meningocele or the myelomeningocele are visible as a sac over the spine. The neurological deficit is going to depend on the level of the defect and the status of the nerve tissue. Sensory and motor function below the level of the herniation is most likely impaired. Treatment will be surgical repair. We will have to fix the nerve endings. We'll have to stabilize the spine. We'll have to close the defect. And then occupational and physical therapy after the repair for any hopeful functioning below the level of the defect. Cerebral palsy is a motor dysfunction disorder. There are lots of different causes, and you can read those for yourself, but there's a bunch of different causes. We don't know for sure. There's a lot of discussion about hypoxia and brain damage, but there's no solid answer as to why. Damage may occur before, during, or shortly after birth. Something happens. Don't know exactly. Brain tissue is altered. Mechanical trauma, malformation, hypoxia, hemorrhage. At any rate, there's necrosis. There can be single factors. There can be multiple factors. Hypoxia or hypoxemia mean major brain damage. It can be caused by placental complications. A difficult delivery, vascular occlusion, hemorrhage, aspiration, all the things that you see listed here. High bilirubin levels too. And that's why we are checking billies on babies as soon as they're born. And you've seen billy lights probably if you've been in clinical. So, infection and metabolic abnormalities like hypoglycemia in the mom. All right. A spastic paralysis then. It results from damage to the pyramidal tracts, the motor cortex, the general cortical damage. Hyperreflexia is what you will see. Hyperreflexia. Dyskinetic disease, where there is damage to the extrapyramidal tract, the basal nuclei, the cranial nerves. There are those choreiform involuntary movements that you may see in dyskinetic disease. And then there's ataxic cerebral palsy, where there's damage to the cerebellum and there's loss of coordination, there's loss of balance. There are other common areas of dysfunction, and you can see those here: intellectual function, communication. Sometimes, primarily the communication is because of the motor dysfunction and the inability to speak, not because they're not normal intelligence, but because they just motor-wise can't say the words. So intelligence can be impaired. They can go from normal intelligence to severely disabled. Seizures are a possibility, and visual and hearing problems. Treatment is individualized and immediate. There are lots of programs for stimulation. There are programs for physical and occupational therapy from birth. There are speech therapy. There are devices that will be given. You've seen a lot of little braces and casts and special walkers and wheelchairs and things like that, standing tables. There are boards to use for communication. So there's lots of different things that we can do to accommodate this child. Let's stop here, I think. I'm trying to remember where we went to. 76. Let's stop here, and I'll see if I can get the rest on one more recording.